the clickers. I can go up there now.
Good morning, everybody. Hello again. Professor Gressner and myself, we are very happy to welcome you again this morning here. I think we are looking to a very interesting session here covering 3 very different topics. And this is also the reason why we thought we should have the discussion right after each presentation. And I'm very much looking forward to it.
Yeah, thank you, Judith. Welcome from my side. It's a big pleasure that Professor Sheldon Cheskes will start with the first presentation. He's a professor of emergency medicine, University of Toronto in Canada. When I look in his agenda and see all his titles and things what he's doing, I can say the most important, I think, is your research on cardiac arrest. You're one of the principal investigators of CANROC, the Canadian Resuscitation Outcome Consortium, and you're talking about a topic that I think after the publication came out, a lot of people thought about, what the hell are they doing? So tell us more.
You're going to learn a lot more today. Thank you so much for the warm introduction. And first of all, Johannes, thank you so much. And the people of Austria for having us. My wife and I we just love Graz, just a beautiful city. And as I travel around the world speaking about double sequential, and particularly in Europe, I love the interest, and you can see there's keen interest in this technique in Europe. But seeing all the cities, seeing the history of Europe, I just love it, and who knows, hopefully we'll come back again one time. So thank you so much for having us both. So let's learn a little bit about the topic of double sequential. You'll all be experts after this talk. So here's the extent of my German, the title, other than Dankeschön. Okay, I don't know any other German. This will be a full English talk for you folks. So my disclosure slides and my research funding slide. For me, I always like to acknowledge my co-investigators. Many of these are legends in the world of resuscitation science, but for this particular work that we did, the stars of this show were the 4,000 paramedics we trained in the technique of double sequential external defibrillation. I've done tons of trials in resuscitation in the past. I have never had a trial where the paramedics bought into the trial as much as double sequential defibrillation. And for me, if I could make them co-investigators, they would all be co-investigators in the trial. They were that good in this particular trial. So why is there so much interest in this concept of refractory VF? And I think the reason there's so much interest is because for years, our idea of what successful defibrillation is has been, in my mind, very, very questionable. What you'll see here in this slide, and this is from a large Swedish consortium and registry, you'll see that survival from VF really drops off in relation to number of shocks. So once you get to 3 shocks, survival drops off like a cliff. And I think that's why you see techniques such as double sequential ECMO focus on this early phase of resuscitation so much. And what you'll see here is what we've thought about is standard defibrillation and successful defibrillation. So here in this slide, you'll see during the first 3 shocks, this concept of VF termination looks pretty good, eh? About 75% of the time you terminate VF, and we've thought of that as successful defibrillation. But what we need to realize is, in fact, almost 85% of those go back into VF again. So these patients who have short-term successful defibrillation, to me, that's not successful at all because they're back in VF again. And what you'll learn after this talk is double sequential is a much more effective technique to terminate VF permanently. And that's why we looked at it. So by background, many patients, as you know, as we've seen, remain in VF after multiple defibrillation attempts. The technique of double sequential and vector change defibrillation have long been looked at as alternate defibrillation strategies, but there's never been any high-quality evidence to support or refute the use of double sequential defibrillation. In fact, there has never been a randomized trial before this, and in fact, the ILCOR, ERC, and AHA guidelines did not support the use of DSED prior to our trial. So the research question we had was amongst adult patients presenting in refractory VF during out-of-hospital cardiac arrest, does double sequential or vector change defibrillation result in greater rates of survival to hospital discharge than standard defibrillation? The study itself was a relatively complex three-arm cluster randomized trial with crossover. We had 6 participating EMS agencies in Ontario, Canada. The study went for just over 4 years. The study had a 6-minute halt phase during the early phases of COVID, and the DSMB recommended stopping the trial in May of 2022 due to COVID-related challenges at our paramedic services. Primary outcome of our study was survival of hospital discharge, secondary outcomes of ROSC, VF termination, and neurologically intact survival with a modified Rankin scale score less than or equal to 2. So when we first decided the trial, many people said, hey, this would have been much easier if we had a 2-arm trial. Standard DSED. But we really wanted to focus on if in fact DSED worked, was it vector, was it energy, or was it perhaps a combination of the two? And that's when we did a 3-arm trial. The inclusion criteria, patients had to present in VF or VT, they had to receive standard ALS therapy if available, they had to have a minimum of 3 successive shocks given and still be in VF at the 4th rhythm analysis. The pads at that point in time were placed in the AL position. Very important to know, they had to be successive shocks. So if someone went VF, PEA, VF, they were not included. VF, VF, PEA, they were not included. They had to be VF, VF, VF. So really the most refractory of all. After the first 3 shocks, services were randomized to one of 3 strategies: continuing defibrillation and care with the pads in the AL position, otherwise standard defibrillation. The second strategy is we removed the AL pads, placed a new set of AP pads, otherwise known as vector change defibrillation, and all further shocks were given in this position. The third strategy was a second defibrillator was brought, 2 defibrillators, one with pads in the AL, second with pads in AP position, in sequential shocking through 2 defibrillators, otherwise known as double sequential external defibrillation. Our paramedic training was all in person as well as online. All hands-on training occurred for all both ALS and BLS paramedics. So this included all paramedics, not just advanced care paramedics. All the cases received feedback from local PIs as to challenges to doing DSED in the field, and I think this close relationship between the paramedics and the medical oversight really helped the compliance within this particular trial. If you look here at our consort diagram of our patient population, 405 patients were actually enrolled in the trial, and as you'd expect from cluster randomization, very nicely distributed between standard, vector, and double sequential. 88% of the patients received the allocated strategy, which we think in a real-world trial is actually excellent. And we'll talk about those who had crossovers so people understand that. When you look at the demographics, I'm sorry for the males here, about 85% of people in refractory VF were male. And the reason for that, when you think about defibrillation, is really quite simple. Defibrillation is very much dependent on transthoracic impedance. It's not energy, it's current that goes through the ventricle. That's of most importance. Males have thicker chest walls, higher rates of hypertension, higher rates of LVH. Males are much more difficult to defibrillate than females, so it's not unusual to see this. High rates of bystander CPR, which I really love, not quite European standards, but when I first started about 30 years ago in Ontario, we were about 30% bystander CPR. You see here almost 60% in this particular study. Public location was a little bit higher than previous trials. The one thing people always wanted to ask about is, can you do vector change and double sequential and still maintain CPR quality? And I think that's a critical piece. Every other study that's looked at this question never reports CPR quality. And you'll see in this slide here, whether the patient was randomized to standard, vector, or double sequential, patients got guideline compliant CPR quality regardless of the intervention. And I think that's a critical piece. If in fact, I think there's plenty of interventions out there that are very effective. But if the preceding CPR quality is poor, the intervention will fail. And I think this was a critical reason as to why this intervention was found to be successful. If you look at event characteristics, time to epinephrine, amount of epinephrine, time of antiarrhythmic, amount of antiarrhythmic, all the same across the three arms. And that, again, is what you'd expect in cluster randomization. You'll see that the number of shocks to ROSC is very similar in the three arms, but remember, those in vector double sequential had to have a minimum of 3 failed standard shocks before they got an intervention shock, so they only needed 1 or 2 vector change or DSED shocks to obtain ROSC. The primary and secondary outcomes, unadjusted, this is where you see all the headlines. All the primary and secondary outcomes were improved in the intervention arms compared to standard defibrillation. Most importantly, survival of 30.4% in the DSED arm, 21.7% in vector, 13.3% in the standard arm. But really in cluster randomization, that really doesn't matter. The adjusted odds is what you want to see. And what you see here, again, DSED adjusted superior to standard defibrillation for all primary and secondary outcomes. Vector change was superior for VF termination and survival, but not neurologically intact survival. So really, this is the first ever RCT exploring different defibrillation strategies for refractory VF. As you saw, DSED was superior for all primary and secondary outcomes, vector change for VF termination and survival. And in fact, what was interesting, we did multiple sensitivity analysis. They were all the same. DSED was superior. Vector change was up and down. Some yes, some they weren't, but not for neurologically intact survival. So the strengths of the study itself, it's cluster crossover design, high quality CPR regardless of the arm that the patient was randomized to. We included patient important outcomes, and importantly, we had almost 0 missing data. Clearly, you can't blind the paramedics. You couldn't blind them to DSED, but people who assessed survival and neurointact survival were blinded to the arm the patient was randomized to. We think the study is very generalizable. We did in both rural and urban centers. We did it both with ALS and BLS paramedic. We used both Zoll and Stryker defibrillators. And very, very important for the people here, we never damage a defibrillator. That's the big concern about the defibrillator manufacturers. We didn't blow anything up. And I think that was really a huge portion, and really the reason many of them were not happy with us actually even doing this particular trial. And we'll talk about damage in a second. Limitations, COVID. If I was a genius, I knew COVID-19 was coming. But to do a trial in the middle of a pandemic was a real challenge. But let me understand this. Almost every trial in pre-hospital care stopped during COVID. Our paramedics did this trial for 18 months during COVID. Full PPE, doing DSED, that's a real compliment to them. So they did that during this trial. People will let you know that early termination always has a chance to overestimate an effect size. The trouble with that is you have to understand that is true if you stop for feasibility. This trial was not stopped for feasibility, was not stopped for superiority, pardon me. So if you stop for superiority, this is an issue. We did not stop for superiority. We stopped for feasibility, and I think that's an important difference between the two. And I can tell you, even in our data during all the phases of the trial, the results were exactly the same. Pre-pandemic, post-pandemic, it didn't budge an inch. So our findings were very, very consistent. Protocol compliance, 88%. It's not perfect, but in a real-world study, I think we're paramedics out here where you folks work. I think that's actually a really great job. We didn't collect ED or in-hospital care. I'm going to show you a little bit of that today. So you see this data and you say, as we mentioned earlier, what's the biological plausibility? Why should DSED or vector change work? And I think the big difference really for us, when you look at vector change, look at here, cross-section of the thorax, well-placed AL pads, you miss 50% of the ventricle with defibrillation. Yet when you do vector change, what you actually do is you incorporate a portion of the ventricle that may have been missed during your standard AL pad placement. We think that with DSED, you have a more homogeneous distribution of energy across the ventricle. We also think that the VF waveform after the first of 2 shocks may not be the same and may be susceptible to the second shock, but there's no question whatsoever. We saw this in every case. There was a 30% drop in impedance in the AP pad of DSED and the vector change pad compared to the previously failed AL pad. That's a critical finding. And because of that change in impedance, what you get through the ventricle is more current, and that's what makes a difference. And that's really, I think, the mechanism by which DSED works. So some of this stuff everyone can get in New England Journal. I'm going to tell you now what you can't get in New England Journal. And that's the challenges we went through during this trial. Biggest challenge, the defibrillator manufacturers themselves. They hate me. Okay? But I think one of the biggest challenges was truly Stryker. Stryker Corporation was a huge challenge. They had in North America a letter out to EMS services that if in fact you did DSED and the defibrillator got damaged, we would not cover your warranty. Listen, you got a couple small agencies out there who don't have a lot of defibrillators. That could really say, hey, we may not want to do this. So myself and Paul Dorian, who's a world expert, a senior author on our paper in EPS, had to go to our EMS directors and say, hey, we know EPS. There is 0 chance doing sequential DSED of damaging a defibrillator. Thank God our EMS directors agreed with us, or Johannes would never invite me here because we'd never do the trial. So we were really happy that that actually happened. Protocol, listen, when you write a protocol in pre-hospital care, if it's done perfectly, they'd have 3 shocks, and shock 4 would be an intervention shock if they're randomized to vector or double sequential. But paramedics in the room know not everything goes perfect. You have a cardiac arrest in a washroom. You have it in a tight quarter. You have it on the side of the street. You have it on a bus. Sometimes shock 4 could not be a vector or DSED shock, and those patients got standard defibrillation as opposed to what they randomized to. When you look at that crossover, every case was like that. We did not have a single case where a paramedic did not want to do the intervention they were allotted to. So it's all related to the geography. Omicron, hey man, if I was smart and knew Omicron was coming, I would have made a different type of protocol. But Omicron ended the trial. And the reason it ended the trial was because at that point of Omicron, 50% of our paramedics were off with COVID. The other 50% were in the hallways, similar to this trial you saw, Simon. So services were randomized to double sequential and vector. By the time they got to the patient was on shock 6 or 7 that was given previously by previous firefighters that were there, had given these shocks. So you basically had created a situation where the hypothesis was biased towards the null. You would just simply be giving late DSED, replicating observational research that had already been done. And that's why the DSMB smartly ended the trial, because you could not do the intervention early. This is all about early DSED, not late DSED. When we look at neurological intact status, people think that every time you have a cardiac arrest, people are neurologically compromised. In this trial, 85% of patients had a modified Rankin scale score less than or equal to 2. Best in DSED, vector was a little bit lower, and in fact, standard was about somewhere in between the two. But when we tease this out, take a look at this slide. Look at the proportion of patients with DSED who had a modified Rankin scale score of 0. They went out perfectly normal. And the best part of this is a story we had. We had a nice lady call me that her husband had a cardiac arrest in refractory VF, and they were randomized to DSED. And she says to me, Dr. Cheskes, I don't know what you did with that DSED stuff, but he's smarter now than before his arrest. So, I don't know what happened, but something there happened. So these people do really well. And the reason they do well, and this is going to come out in future studies, is it's all related to the time you spend in VF. DSED decreases the time in VF. therefore decreasing low flow time, therefore improving neurologically intact status. Remember I said that if ALS was available, they were there. But we had 8% of our patients had no ALS, no IV, no advanced airway, no epinephrine, no antiarrhythmic. Guess what? 50% survival in that subgroup of patients. So that tells you what's important is not all the drugs, it's defibrillation. That's the most important thing in this particular paper. So we've got now a number of secondary manuscripts that have come out. We've published 3 in the last 3 months. You'll see here one looks at the timing of DSED. So the timing of the 2 shocks. Prior to the trial in our area, we were actually doing simultaneous DSED as opposed to the sequential part that happened during the trial. And what we found in relation to timing was in fact the shorter time intervals were related to better rates of VF termination to ROSC than the sequential process that we did. So if Simon Orlob is here, the future, I will guarantee you, will be a single defibrillator, 4 pads, 1 button, and the shocks given at 70 milliseconds apart. That's the optimum defibrillation, and you'll see that as time goes by. The next one is people wondered about, could it have been angiography or PCI that had the benefit in the results? And this had nothing to do with DSED. But when we looked at this particular paper, what we found, no differences in angiography, no differences in PCI amongst the 3 groups. In fact, when we look at patients with STEMI and no STEMI, you'll see patients with STEMI, high rates of angio, high rates of PCI, high rates of survival. But what's interesting, no evidence of STEMI, lower rates of angio and PCI as one would expect, but still 50% survival in the no STEMI group. And the reason for that is the vast majority of those patients were randomized to vector change or double sequential, less time in VF. So I think that's key. This next paper just came out now. It's hot out of the press, perfectly for Graz, and this is a really important paper. This, I think, will be the most important paper we published. Many people argue, and mainly the EPS group, that these patients aren't in refractory VF. These patients are actually in recurrent VF. So they go into VF, they stop for a short period of time, and then they go back into VF again. And the defibrillator manufacturers would have you think that if someone's in recurrent VF, it's not defibrillation that's the problem. It's an LAD lesion that needs to be opened up. It's something different than defibrillation. So what we did is we took all the patients who got the per protocol patients, so everyone who got what they were randomized to, and we then looked at how those patients fared, refractory versus recurrent, in relation to the defibrillation strategy. The refractory group, there it says it all, 29% DSED, not a single patient who had true refractory VF survived standard defibrillation, not a single one. But the more important question, what about the recurrent VF? Almost a doubling of survival in the recurrent VF group with DSED compared to standard defibrillation. What this tells you is you want to prevent refibrillation, do more effective defibrillation in the first place. Forget about the drugs, more effective defibrillation is the key. If I was going to do dose VF2, it would be double sequential versus vector change. That would be what I would do. There's 4 studies out there right now, Sweden, Norway, Denmark. Sweden, Norway, Denmark are looking at DSED after the first shock. Okay, so that's a different question. So that's looking at early DSED. The last one is by Steven Katzenberger in Heidelberg in Germany. He's looking at DSED versus standard defibrillation after 3 shocks. So there's going to be a lot of research out there looking at this question. Are we ready for prime time? I always say, and Laurie Morrison, my mentor, always said to me, when you're doing your science, when you do an RCT, do your best science and let that science speak for itself. I can say right now in DSED, there's no science like this, because this is the only randomized trial out there. And that's why the ILCOR recommendations suggested a double sequential strategy now be considered in standard defibrillation for patients who meet the study criteria and have the availability. The three controversies, and I'll be really quick for this. One is, should I do DSED or vector change? For our money, 100%, if you have two defibrillators, it should be DSED. The reason for that, the point estimate sensitivity analysis. For us, the fragility index is a number of cases that have to go from positive to negative to change your study outcome. Fragility index for DSED was 9, vector change was only 1. Whenever you see a fragility index of 1, that's a yellow light. That's an amber light saying, hey, this doesn't take much to flip the findings. DSED, the only one with neurologically intact survival, that was superior. ECMO or DSED for refractory VF. I've spoken with Dimitri Anopoulos and my friends in France as well, and we've all agreed. These are not two strategies that fight against each other in refractory VF. Many of them are done complementary. And in many of these areas now, you will get DSED first. If you fail that, they move to they'll move to an ECMO strategy. And the reason why is just right here. This is a sub-look at the Prague ECMO study. And what you see in the Prague ECMO study is if you got pre-hospital ROSC, your CPC score was way higher than no pre-hospital ROSC in ECMO, no pre-hospital ROSC in ALS. So what this tells you is ECMO is cool, ROSC is a lot better. I think that's really, really important. Last controversy, science versus technology. I can tell you, you may not be doing this in Graz, but you're going to soon. Lots of people doing DSED, okay? The defibrillator manufacturers are pissed because it's not on label. So we had a meeting at the AHA, we had the FDA there, and we're looking at developing a process to make DSED an on-label use of defibrillation. So just in conclusion, DSED is superior to standard defibrillation, all primary and secondary outcomes. Vector change superior for VF termination survival to hospital discharge. Both strategies should be considered early in the management of refractory VF, and I mean early. If you don't have this choreographed after the first 3 shocks, you're going to fail. You're just going to simply repeat the mistakes that have made in the past. DSED outcomes consistent amongst multiple sensitivity analysis. We think vector change should be entertained. In rural areas, single defibrillator areas, that's where you look at vector change. Further information, obviously, is in the paper, and I'm more than happy to answer so many questions. So thank you so much for your time. It's been a real honor to speak today.
Jen, thank you so much for that presentation and your clear statements. Are there any questions from the audience? If there are, yes, stand up and speak loud. First this one, then the second one.
Very good. So the energies when we went to DSED was always the maximum of the defibrillator that we used. So if we used a Zoll defibrillator, 200. If we used a Stryker defibrillator, 360. But remember what I said, not so much the energy, the key is the current that goes through. So different biphasic waveforms may behave differently, but it's really not the energy, it's really the impedance, and that's really important.
Thank you. Second question there.
Thank you very much. Could you please comment on the resources on scene? So maybe the first part, how was the second defibrillator delivered to the scene? And the second part, were there equal amount of paramedics and personnel on scene in each of the groups?
Very good. Yes, there were. So one thing about North America, we have tons of paramedics, we have firefighters. So it was never an issue of resources. We always had the defibrillators there. How we do it, and we have plenty of training slides, so if anyone needs training slides, we've done DSED, manual and AED, AED and AED, and 2 manual defibrillators. We've done them with all. And we have training slides, happy to share them with you. How we do that is the following. After the first 3 shocks, we do 30 compressions, 2 ventilations, log roll the patient posterior pad. We do 30 compressions, 2 ventilations, place the anterior pad of the second defibrillator, 1 full minute of CPR, and then we do the sequential DSED. So that's why that process of churning the patient and placing the pads took less time than putting on a mechanical CPR device. So that's why I think you see the really high chest compression fractions even in the DSED arm.
There was another question here. Can you
Yes,
over the
thank you
microphone?
for presenting this amazing trial here today. What I would be interested in, were there any differences between the two defibrillators that you used, because you used different energy levels, as already mentioned? I couldn't find it in the manuscript.
Yeah, so that's such a good question. That'll be I think that's something, we have so many papers coming out. And one of the next papers will be an impedance paper, because I think that's key to the mechanism. The question is a Stryker defibrillator better than a Zoll defibrillator? More importantly, is the waveform different? Because the waveforms are once they're measuring the pre-shock waveform, sometimes the impedance is fixed, sometimes the impedance is changing. So the question is, it's going to be really hard to separate that out with the other characteristics of the resuscitation in those particular agencies. So we're going to look at that particular question. It'll be very tricky to really tease that out. I do have a gut answer, but I'll tell you later.
Thank you.
There was one question there, and then after that. Sorry, you can use this one. First person in the back.
All right. So my question would be, if you have two defibrillators from two different vendors, which is probably not recommended or was not part of your trial, but in real world setting, what do you recommend to use if one defibrillator is capped at 200 joule and the other one takes 360? So I would guess that you take the one with the 200 joule first and in the second shock with the higher energy. But what is your recommendation for the meantime where we don't have?
Yeah, that's a great question. Device. So we did have it in our trial. We did have, so we had many times, we had a Stryker defibrillator and a Zoll AED, or the other way around. So we had a number of cases like that. We didn't go by the energy, we went by a standard process that the paramedics could do. So we had, whenever the first shock was always the first defibrillator on, second shock, the second defibrillator on. That way was never screwed up. Because if we did that differently with different defibrillators, it'd be a problem. So always the AL was the first shock, always the AP was the second shock, regardless of the defibrillator on.
So last question from Professor Burke.
That's great, Sheldon. This was a terrific trial. There's one thing you said there that's a little confusing in terms of my understanding of VF. Clearly, the current density is the critical thing, not just the current. There's the current that goes right through the heart, and you showed that very nicely. But what's a little bit confusing to me is that you said that if you had a first defibrillation work, that you would have been better off if you had this technique instead of any other technique. But my understanding is, traditionally, it worked because it stopped all fibrillation. It stopped this reentry rhythm. It's not a chaotic rhythm. It's a reentry rhythm. It has a vector, and once you stop it, in theory, in the history of VF, you were supposed to have stopped it, and that was enough. Why do you think that that's not enough? What's the biological reason?
So this is the key. This is very important from an EPS point of view. To stop recurrent VF, you must annihilate every myocyte. If there's any fibrillation of any myocyte, the ventricle goes back into VF. And what we saw in the cases of recurrent VF, it was classic. You actually have an episode post-shock of asystole. Yep. It stops, and then with CPR, QRS, 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 and the patient gets ROSC. Most people would think you defibrillate them into a PEA rhythm, and then they just pick up and they get blood pressure. It's actually more common to annihilate every myocyte, have an asystolic rhythm, and then they wake up again. And all the fibrillating myocytes have been stopped through the use of DSED. That's what we saw in our stuff.
Okay, there may be other questions, but there will be time after the presentation, so we can thank you again for your presentation.
Thank you.
A big applause for you.
Thanks so much.